Okay. Okay, good evening. Bruce Arroll's my name. I'm the director of the Goodfellow Unit, and my guest tonight is Professor John Kolbe from the Department of Medicine at the medical school. Tonight we're going to be talking about asthma, so adult asthma, not children's asthma. And I'm just going to say a little bit about the Goodfellow Unit. Okay, so just a little bit about the Goodfellow Unit. Hopefully most of you are already signed up to the Goodfellow Unit, but this is our front page. We have the online catalogue. We have the annual symposium coming up in a couple of weeks with about 100 different sessions. We have Goodfellow events and we have Goodfellow clinics. This is part of Goodfellow clinics. We have the gyms, so this is the practice changing fact every 2 weeks. So the latest one is shorter courses, better for pneumonia and cellulitis, and longer courses so long as people are stable. So that's the latest gym. The answers in the title, so you don't need to read them if you're familiar with that. These are the podcasts. So we've got our latest one with Tim Keneally on the diagnosing of diabetes, and as you can see there, we've got psoriasis with Paul Jarrett, topical antibiotics with Emma Best, transient ischemic attacks with Alan Barber, and Nicola Dalbeth with an update on gout. So they're all people, well-known people and good teachers. And this is our YouTube channel. So if you go to YouTube and put in Goodfellow Unit, you can see videos of the symposium from last year, the keynote speakers that were videoed. And there's also a whole lot of videos there on women's health. So from the Women's Health Day, which was held in November last year. So okay, and we've got links here to the British Thoracic Society guidelines on asthma and the New Zealand guidelines on asthma. And there'll be a link on the website to this once we've finished. Okay, so I'm going to just hand over to John now. Feel free to send in questions. We will try and synchronize the questions, but and we will break the questions as well, so just to break up the evening. So if I can hand over to you, John, if you'd just like to start talking about asthma, and then we'll take it from there.
Thanks very much, Bruce. I might just go back to that slide that shows the guidelines to make the point that this is not meant to be a comprehensive talk or lecture on asthma or adult asthma. If you really want to know about adult asthma, then I suggest you go to these guidelines. I put together some slides, and I regard those as hopefully being stimuli for questions from you, because I'd much rather answer your questions than give some sort of didactic talk. So the first slide is on the diagnosis of asthma. It's interesting. Bruce sent out my initial fairly rough notes on the outline for this presentation, and we got a feedback that said, well, one of the features of asthma is that it starts in childhood, which then begs the question of why I have a slide on the diagnosis of asthma in adulthood. And therefore I thought that probably the first thing I should do would be to address that question. And that's relatively easy to do, because there's just been published the results of, some further results from a big longitudinal epidemiologic study from Tasmania. And this particular paper looks at people who have asthma at the age of 44 years. So either have symptoms of asthma or they're on treatment for asthma. Half of them had asthma diagnosed in childhood, that is 13 years or less, but half of them were diagnosed as adults. So if you take people who have asthma in middle age, about half of them will have adult onset asthma. Admittedly, those who were diagnosed in childhood were more likely to have associated atopy. So I think everyone knows the symptoms of asthma: shortness of breath, wheeze and chest tightness. I find it valuable to ask the patient what they mean by wheeze. and often you get the answer that, oh, it's a crackling sound in my throat, which I think most of us would agree is not wheeze, as opposed to the continuous whistling sound that characterises wheeze. So shortness of breath, wheeze and chest tightness are characteristic symptoms of asthma. Cough is a very uncommon sole manifestation of asthma. I think, unfortunately, we were done a great disservice 20 or 30 years ago with that paper in the New England Journal of Medicine that talked about cough variant asthma. So cough variant asthma is very uncommon in adulthood, and when I speak to my paediatric colleagues, they consider it to be very uncommon in childhood as well. So cough as a sole manifestation of asthma is in fact very uncommon. Now, of course, asthma is characterised by variable and recurrent symptoms, so the shortness of breath is worse from day to day or at different times of the day, particularly the diurnal variation is such that the symptoms are worse in the early hours of the morning or on rising. And as I said, there's an association with atopy, particularly in those who have childhood onset of asthma. And the asthma then, or the symptoms, if we're thinking about this diagnosis of asthma, then the symptoms may be seasonal. This person presenting at the same month of the year as they did as in previous years with these symptoms. Exercise-induced symptoms, unless that is wheeze and disproportionate shortness of breath, that's challenging. It's worse after viral respiratory tract infections, and this is it's probably not terribly fruitful to argue as to whether this is asthma or this concept of post-infection airway hyperresponsiveness that tends to be self-limiting, albeit over months. I've already talked about nocturnal symptoms. Exposures, which can be non-specific, like cigarette smoke, can be specific, such as some of the occupational exposures that can aggravate or even cause asthma. Remember drugs, beta blockers, including beta blocker eye drops, and non-steroidal anti-inflammatories. And remember that increasingly obesity is associated. There's an association between obesity and asthma. That is a real association, albeit although it was only described about 20 years ago in the nurses, that big epidemiologic study of nurses. But there is no doubt that with increasing BMI, there is an increased risk of asthma. And these people have wheeze, and if you actually challenge them, they have airway hyperresponsiveness. Remember, it's a bit more challenging to make the diagnosis of asthma in obese people because of their obesity tends to reduce their forced vital capacity and therefore normalise their FEV1 FVC ratio. We don't know what the mechanisms are, whether it's the pro-inflammatory environment that's associated with obesity, whether it's got something to do with the non-compliant chest wall not stretching airway smooth muscle, we don't know. But there's a genuine association with obesity, and there are two other important things about obesity and asthma. One, they tend to be less responsive to steroids, oral or inhaled, and they respond to weight reduction, either weight reduction through diet or exercise or weight reduction through bariatric surgery.
John, I've got a question, and I've got a question I wanted to ask you. So we're back on now, so that the troops can see us. So this is a question from Jess. We have a chronic cough patient that comes out of clinic with inhalers. Why? What do you think that's about?
If you mean comes out of the hospital clinic with inhalers, I suspect that might be a sign of some desperation, but I do come back to the fact that cough is a very uncommon sole manifestation of asthma. So I think that if if you really thought that that patient's cough was on the basis of asthma, or this rather difficult to pin down eosinophilic bronchitis or eosinophilic airway inflammation, then I think I'd probably do two tests. I would measure their expired nitric oxide, which gives you an idea about eosinophilic airway inflammation, and I would see whether they had airway hyperresponsiveness. And if their expired nitric oxide was normal and they didn't have airway hyperresponsiveness, I think it's exceedingly unlikely that they have clinical asthma.
Okay. And just one other question. I was looking at something recently, and it said that 30% of patients with a diagnosis of asthma didn't actually have asthma. So what's happening there? Are these people who've had a viral bout and then somebody said, well, you've got asthma, and gone on from there, whereas in fact they probably would have got better given time?
I think probably the answer is complicated, and I suspect that there are many and varied reasons. I think one is this assumption that many people who present with cough actually have asthma, and I think that leads to people being inappropriately put on inhaled therapy. And the second, as you quite correctly say, is the transient wheeze that follows respiratory tract infections. And then the third is that just because you don't have asthma right now doesn't mean that you didn't have asthma a year ago. Airway hyperresponsiveness is not a stable parameter, and those who have very, very mild disease can move from having normal levels of airway responsiveness to abnormal levels of airway responsiveness, possibly in association with respiratory tract infections, but also in association with exposure to allergens.
Another question here, John. I'm sure you'll get a Nobel Prize if you got the answer to this one.
Yeah.
For obese patients, what do you find are the most effective and easily implemented changes to help them reduce their weight? Because in primary care, we virtually get nobody to lose weight.
Yeah.
I don't know, do respiratory physicians have more success?
Well, as half of our outpatient clinics these days are for sleep disordered breathing, and we're really only allowed to see people with sleep disordered breathing, not other sleep disorders, I spend a significant amount of time seeing people who have obstructive sleep apnea or obesity hypoventilation. Yes, I agree with Bruce. I'd be looking for the Nobel Prize if I had the answer to that. So I'm sorry, I don't know, but I suspect that I give the same sort of advice that the person as the person who asked that question.
Well, one of my favourite tricks with an audience of GPs is to ask the audience, how many of you managed to get someone to lose 5 kilograms and keep it off for 10 years? And out of 100 people, there's one person who puts their hand up.
Yeah.
So I think in 2017, in New Zealand, it's very hard to get people to lose weight.
Yeah.
I know Boyd Swinburne, who's based here at Tamaki, says that he's more interested in helping people maintain their weight rather than try and lose it. Like losing it as a hiding to nothing. If you can maintain your weight, maybe that's a reasonable outcome. So, okay, so we've got a few questions here. How do you test for airway hyperresponsiveness?
Yeah, may I cover that? And I see another question about expired nitric oxide. Can I cover that on another slide, please?
Yeah, where you go.
All right?
So we'll go back to the slides, John. Here we go. Yep, carry on.
I probably need to be able to.
Yeah,
I think you need to click something.
Is that me over there? Yeah.
There we are. So those questions were well asked or well timed. So what about the role of pulmonary physiology in the diagnosis of asthma? So we are turning to physiology when we are still unsure of the diagnosis after taking a history and doing a physical examination. So so the first thing we're going to do is to undertake spirometry. And the point to make there is that baseline airflow obstruction is often not present when you do your lung function tests. So even though the patient might have bona fide asthma, if they have mild asthma, they may not have airflow obstruction when you first do the spirometry. The next sentence there is use the lower limit of normal for the ratio. So many of you are probably taught that the FEV1 /FVC ratio is 0.7. And in fact, it's higher than that for young people, and it's lower than that normally for older people. So it's a bit like when your watch stops, it's only right twice a day. So the FEV1 FVC ratio will only be correct for a very small proportion of patients if you use the fixed value of 0.7. And so what tends to happen if you use 0.7 is you underdiagnose airflow obstruction in young people and overdiagnose it in older people. And many of you will have spirometers that show the flow volume loop. And there are two expiratory loops shown there. So what I've got is volume on the x-axis and flow on the y-axis, and you can see that to your left, close to the zero, is at total lung capacity. So that's after you've taken a complete breath in and then you blow it out as hard and as fast as you can. And you can see that the flow rate dramatically increases very rapidly to a peak, which surprisingly enough is called peak expiratory flow. And then after that, flow falls off almost linearly with volume. And of course, the extent of that curve on the x-axis is your forced vital capacity. Time's not shown on that, so you can't intuitively pick FEV1 on that. But so your normal curve looks almost like a right angle. And when you start to develop airflow obstruction, the curve tends to sag. In other words, it becomes concave upwards. And so those of you who can get a picture of the flow volume loop on your spirometer, one of the things that you should look at is the shape of the flow volume curve and looking for that sag. The peak flow might be reduced, but remember that there is a very, very wide variation of normal in peak flow. And so peak flow is very good at monitoring the course of an individual patient, but it's not so good at distinguishing normality from abnormality. So the other thing that we're all taught as medical students is that you can also look for variable airflow obstruction in people that you suspect of having asthma. So you look at variations in peak flow. And yes, that can be very useful if you've got a patient who is almost obsessive. Because one of the things you've got to remember is that peak flow is very, very sensitive to effort. So if they don't do a proper forced expiratory manoeuvre each time they measure their peak flow, you'll get, excuse me, great variations in peak flow that have got nothing to do with their airflow obstruction. So just be a bit careful in the interpretation of peak flow monitoring. The diagnosis of asthma is said to be based on reversible airflow obstruction. That is an acute bronchodilator response. And that's defined as a greater than 12% improvement in FEV1, and that improvement's also got to be more than 200 mils. That's a bit more relevant in COPD than in asthma. Can I just say that it's pretty uncommon to actually demonstrate that acute bronchodilator response in my experience. And when often it's used as an inclusion criteria for studies of asthmatics, and we know that people are asthmatic, and we have difficulty demonstrating that, particularly if they are clinically stable. So now we get to the questions that were asked. So if after all of that you're still unclear, then I think that you refer to your local lung function laboratory. And there they will be able to, I'm certainly speaking for Auckland, but I suspect that I'm speaking for all major centres, measuring the expired NO. That's a very, very simple test. It's like blowing into a straw. And the raised expired NO, it gives you information about eosinophilic airway inflammation. So that's all it tells you. It doesn't tell you whether the patient's got asthma or not, and we know that a significant proportion of people who have atopy have asymptomatic elevation of their expired nitric oxide. The other is a challenge test, and that is to see whether the airways are abnormally responsive to a stimulus. And we now only use hypertonic saline as our stimulus. Some of you may have read about or even ordered tests for histamine or methacholine challenge. I think hypertonic saline challenge is better. It's more specific in that it mimics presumably what happens in your asthmatics, in that the hypertonic saline causes degranulation of mast cells, release of bronchoactive mediators, and causes airway narrowing. So it's more specific, and you get away with some of the false positives. That is, it's less sensitive than histamine or methacholine. And so that's why I recommend a hypertonic saline challenge. For those of you who don't know what is involved, the patient inhales a mist of hypertonic saline for a certain period. Sorry, they have baseline FEV1. They inhale a mist of hypertonic saline for a period. Then the FEV1 is repeated. Then they inhale the hypertonic saline for a longer period. FEV1 is repeated, and so forth, until we get to what is arbitrarily defined as the maximum dose or duration. And if you haven't had a reduction in FEV1 by about 12%, then you are defined as not having airway hyperresponsiveness. Remember what I said before, that this is airway hyperresponsiveness is not necessarily a stable parameter, and the percent drop to 12% is somewhat arbitrary. So if you had someone who you thought had very suggestive symptoms, and they have a drop of 11% rather than 12% in their hypertonic saline challenge, I'd still regard them as being very suspicious that they actually have underlying asthma.
So I've got a few questions there, John. Let's maybe just get the camera back on so people can see us. So Kyle's question was about how can we access expired nitrous oxygen tests as a GP? Presumably it's something you would refer to the
lung function laboratory. And remember that I'm sorry, I can only really speak about Auckland here, but GPs have equal access to the lung function laboratory as we do as respiratory physicians.
Okay, that's good to know. And a question here from Leanne. In terms of FEV1, FVC ratio not being accurate by using 0.7, is that only for asthma, or is that applicable to obstructive disease in totality, including COPD?
Yes, exactly right. It is applicable to the diagnosis of airflow obstruction at whatever age. And of course it does become very important in terms of the diagnosis of COPD, which would tend to be overestimated if we used a fixed ratio of 0.7. So you're absolutely right. It would be underdiagnosis of airflow obstruction in the young, overdiagnosis in the older patient.
Okay, so keep the questions coming. We'll go back to the slides.
You might have...
Oh, okay, sorry. Is that going? Just try that now.
That's right. You have to click, I think, on the. I don't know. Okay. Click on the slide. Oops. I'm glad Bruce is in charge of the technical things here.
I'm having a moment's here.
Yeah. Okay, so oftentimes, as part of the diagnosis of asthma, we undertake therapeutic trials, and I do that as much as probably any of you do. And of course, probably the best is to have a trial of a short-acting beta agonist, and if the patient gets acute benefit from that, then it is highly suggestive that they have a degree of reversible airflow obstruction. Also, if they have airway inflammation and airway hyperresponsiveness, that generally responds to a course of oral steroids, and so that can also be of some use in the diagnosis of asthma. Inhaled corticosteroids are often used in terms of this therapeutic trial to make the diagnosis of asthma, and I think that was in part relates to Bruce's earlier question as the 30% of patients who are on asthma medications but who might not actually have asthma. Of course, some people do get a good and fairly prompt response to inhaled corticosteroids. But I dug out this slide, which is from a study in Melbourne, which wasn't necessarily looking at the diagnosis of asthma, but it gives you some idea of the time course of response to inhaled corticosteroids. And the lower panel, in that lower panel is a measure of airway hyperresponsiveness. And you can see that the response to inhaled corticosteroids of a lowering of the degree of airway hyperresponsiveness takes place over many months, and it's still improving at 12 months. So inhaled corticosteroids have a relatively slow onset of action, and that the improvement takes place over many months. And so it's important to bear that in mind when using inhaled corticosteroids, either to help you with the diagnosis of asthma, and in terms of when you're speaking to patients in terms of the time course of response to inhaled corticosteroids. So I think it's important to bear that sort of slide in mind. Note that the OFF, that is the worsening of airway hyperresponsiveness, comes on fairly quickly. Notice the worsening of airway responsiveness in the month after withdrawal of inhaled corticosteroids. So slow onset of effect, and unfortunately a rapid deterioration in effect after stopping inhaled corticosteroids. Okay, why might we become confused? Well, the first is to think about asthma mimics, and that is that things can look very much like asthma, and I think of those as either disordered breathing, or what's sometimes called hyperventilation syndrome, or functional laryngeal spasm, sometimes called vocal cord dysfunction. And those are very challenging to distinguish from asthma, particularly in the patient who presents acutely. And then it is really difficult to sort that out. Also important is the fact that these not infrequently coexist with asthma. So the asthmatic often has a degree of hyperventilation and also a degree of vocal cord dysfunction, and so it is very difficult then to tease all of those apart. But the most important thing is that just because someone hyperventilates or has vocal cord dysfunction doesn't completely exclude asthma. So they can have both. So, so just beware there. And when I come to other referrals, it might be sorting out that really difficult situation of how much of this is genuine asthma, how much is hyperventilation, and how much is vocal cord dysfunction. Might be one of the reasons for referring in for a respiratory physician opinion. As I said, much more than a decade ago, that all that wheezes is not asthma, and so it's important to bear that in mind. And remember that cardiac failure, left ventricular failure, you can get airway wall edema, narrowing of the airways, and wheeze. And I have to say that I was very disturbed the other day in a presentation where someone indicated that a patient had been admitted to the intensive care unit 7 times for acute asthma before their severe mitral valve disease was finally diagnosed. So always remember the possibility of cardiac disease. And then there are other respiratory conditions. I'm not going to talk about the differentiation of asthma and COPD tonight. I don't think that we've got that much time, and that's another talk in and of itself. But remember that we have a variety of other diseases. Could this be bronchiectasis? Are we dealing with some other form of respiratory disease?
So I've got a few more questions here, John. This is from Marika. What age is appropriate for what FEV1, FVC, if 0.07 is not universal? Can you give us some sort of range of numbers? You mentioned older, younger.
Yeah. So young people. So if you're using an electronic spirometer, it will tell you that. All right. It will give you the lower limit of normal for the FEV1 FVC ratio. So that's your best go-to. In young people, so people in their 20s, for example, they should have an FEV1 FVC ratio of 80% or even more. Whereas an FEV1 FVC ratio for someone age 70, the lower limit of normal is probably 65% or below.
Great. Okay. What are your thoughts on this is from Robert, what are your thoughts on the usefulness of right peak flow charts using age, sex and height data?
I don't think they're much use. At the risk of unduly complicating things, there's a term called dysynapsis, and this relates airway size to lung parenchymal size. And you might intuitively think that, you know, big lungs mean big airways and vice versa, but that's not always the case. And peak flow basically tells you about the size of your large airways. And so you might have a person of the same age, the same gender and the same height, one who has big airways for their size, the other who has small airways for their size. So one will have a much bigger peak flow than the other. So they'll have a wide range of normality for peak flow, whereas the beauty of FEV1 is that the width of the normal range is much less. So it's much tighter range of normal in FEV1. That's just one of the advantages of FEV1. So I don't think that it's terribly useful for you to use peak flow, even normalised for age, height and gender, as a diagnostic test. As I said, the beauty of peak flows is comparing that individual patient at one time with their status at another time.
Okay, another question here, John. So what dose of oral steroids would you recommend for a therapeutic trial? I guess dose and duration.
Yeah, I know general practitioners like to use 20 milligram doses of prednisone, 20 milligram tablets of prednisone, and so 40 milligrams per day for 2 or 3 days and 20 milligrams per day for 2 or 3 days and then stop. If there, I would be very suspicious if that was not associated with a clinical response in someone whose symptoms were due to asthma. Personally, I don't use doses more than 30 milligrams per day, and I use 5 milligram tablets, but that's because I am looking for the ability to vary the doses probably much more than you are wanting to do in general practice.
Okay, so another question here. Do you work with speech and language therapists to identify vocal cord dysfunction? And if so, how does that work? It's not quite sure what the question is getting.
No, I think it, I actually think it's an exceedingly good question. And the question relates to videoing the vocal cords during various manoeuvres. And what you are looking for in vocal cord dysfunction is paradoxical movement of the cords during expiration. So when we expire, you would expect our vocal cords to abduct, in other words, become wider apart. And people who have vocal cord dysfunction, they have paradoxical movement of their cords that move closer to together on expiration. And that's often used as a, if you like, a diagnostic test for vocal cord dysfunction. The difficulty in asthma and airflow and other forms of airflow obstruction is, of course, that one of the things that patients do to reduce their work of breathing is to do auto-PEEP. And although we are used to thinking of patients producing auto-PEEP by pursed lip breathing, you can also do it by adducting your vocal cords, in other words, bringing your vocal cords closer together. So a degree of adduction of the cords may be normal in many patients with asthma, particularly if they have high airway resistance. But nevertheless, the question is a very, very good one, and I think that that we, and I'm talking about we being respiratory physicians, use speech and language therapists much less than we should, both in terms of with this problem and even to the extent of their role in giving patients with chronic cough, for which we can't find the cause, instructions about cough suppression and so forth. So I think, generally speaking, speech and language therapists are underused for that. However, speaking for Auckland District Health Board, we only have 2 of them, and they are very overworked, and they are, not surprisingly, monopolised by the ORL service rather than the respiratory service.
Okay, question here about why the tapering dose for such a short trial course? I think that's because you suggested 40 milligrams and then 20 milligrams. Why?
Yeah, I accept that. I think that the question is asking, well, if you use 40 milligrams for 3 days, why don't you just stop after that? And I think that would be perfectly reasonable. I guess in my defence, I'm giving the patient a few more days on steroids, but not at such high a dose. But there is very, very, very limited data on oral corticosteroid doses in acute asthma or in the management of acute airways disease generally. There are a few things that we can say, and that is that probably in the context of an acute exacerbation of airways disease, that there's no benefit in using more than 40 milligrams, and you probably need 5 days of treatment. But you know, there was a study from from Brisbane a number of years ago that suggested that 20 milligrams seems to be just as good as 40 milligrams. So I think I will take it on the chin any criticism about doses of oral corticosteroids and duration, because I think it's a relative evidence-free zone.
So the question, person who asked the question about the laryngeal spasm was very, says thank you. So very good answer. Now,
I suspect, because I take the view that they refer to speech and language therapists, so I think I was probably agreeing with
the person. Maybe a speech and language therapist.
They might.
Perhaps we can ask her to identify herself. Okay, so looking at the trial with inhaled steroid, taking a while for it to work, would an oral steroid trial would be a better test than a trial of inhaled steroids?
I guess that's what I was trying to say in that slide. Exactly.
It was extraordinary, actually, how long it took, wasn't it? Yep. Really, but then how quickly it dropped off. You know, it's sort of interesting. It's like fitness, isn't it? It takes a while to get.
Sadly,
you lose it very quickly. Okay, and is somebody going to be testing me? Do you use the Kaufman RSI reflux symptom index to distinguish night cough due to nocturnal reflux from just nocturnal asthma? Does that make sense?
No, I don't use that index, but may I just address that a couple of slides on?
Sure.
Because I think it is an extremely important point, and it's very well made.
Okay, and one more question.
Yep.
Okay. Is there any data about percentage of adult onset asthma that is related to work occupational exposure? This is from Sarita. Could you put a number on it? Again?
No, I can't put a number on it. I will say that it depends on how you define occupational asthma, because I think that there are I guess three sort of categories here. One is the person who has asthma before they enter the workplace and who are exposed to non-specific irritants, dusts and so forth, that makes their asthma worse. The second is the person who may or may not have had asthma but had atopy, who is then exposed in the workplace and either has worsening of asthma or the development de novo of asthma. And an example of that is baker's asthma, where people who have atopy going into the baking industry are much more likely to develop asthma. And then the third is the person who seemingly has no predispositions in terms of atopy, and who, as a result of workplace exposures, develops asthma. Now, that used to be isocyanate-based paints, although I think that health and safety in the workforce now is such that probably no one should be exposed to isocyanate-based paints now. I guess if they had a faulty respirator, that's an exception. And the other is the exposure to Western red cedar, which has been shown to precipitate the development of asthma in people who had no pre-existing propensity to develop asthma. So I can't give you a percentage, but it will depend on which of those three categories you are talking about. But I think that it is always important to take an occupational history. It's always exposure history is always part of a respiratory history. Once you are suspicious, then sorting it out and clearly demonstrating that this is occupational asthma is in fact quite difficult and challenging, and that would be another reason for referral that I haven't got on my list.
Right, carry on, John.
Okay, so what about other diagnoses? I talked about other respiratory conditions, but if you have a severe asthma phenotype, and someone said, what in the feedback that I mentioned earlier, someone said, well, what's severe asthma? Well, you can define severity of asthma in a whole variety of ways. The first is, by a level of airway hyperresponsiveness. The other is by their morbidity. If they're admitted to the ICU, how many hospitalizations they've had. I guess the third is, are they still getting symptoms on what is maximal therapy or near maximal therapy? But I guess there was an editorial about 30 years ago about asthma being like love. It's hard to define, but you kind of know it when you see it. And I think severe asthma is a bit like that. I suspect most people know it when they see it. But severe asthma is in fact uncommon. And so when you see someone who has severe asthma, you think, is this indeed bona fide asthma, that's bad asthma, or am I dealing with something else? So am I dealing with this condition called allergic bronchopulmonary aspergillosis, where the allergic reaction is to the fungus aspergillus that we all breathe in probably on a daily basis. So allergic bronchopulmonary aspergillosis is that ABPA. And the importance of diagnosing that, so that those people present with a severe asthma phenotype requiring a lot of oral steroids. And the importance of making that diagnosis is that there is an intense inflammation of the airways which damages the airways over time. So you develop both fixed airflow obstruction, but also damages the airway wall to produce bronchiectasis. So then you get a really nasty condition that is severe asthma plus bronchiectasis. And the second is, am I dealing with a vasculitis and what I would call Churg-Strauss vasculitis, where the patient presents with an asthma phenotype, often has quite a lot of peripheral blood eosinophilia, although that can be dampened down by courses of oral corticosteroids. So if you do have people with a severe asthma phenotype, should be thinking about the possibility of those things, and I will come to a slide in a moment that says that's an indication for referral.
So as GPs, if we've got people on what we think is maximal therapy and they're not getting better, that would be a good case for referral.
I think so, and I sort of define the limit of therapy on a slide a little bit further along.
Cool, great.
So always think about associated conditions, and this relates to the question that was raised a few moments ago. So in every patient who has airways disease, you should be asking about gastroesophageal reflux and rhinosinusitis. So reflux can aggravate asthma either directly via microaspiration or indirectly via a vagal reflex. Those of you who've got letters from me can see that I parrot that off often in my correspondence. So it's the point that the questioner, I think, was asking is that you should ask for very specific questions about reflux, and could reflux be contributing to their nocturnal symptoms? And I have a very low threshold for introducing a proton pump inhibitor. The second is rhinosinusitis. Obviously, the airway, the mucosal lining of the upper respiratory tract is the same as the airway lining of the lower respiratory tract. So something that affects lower airway mucosa is likely also to affect upper airway mucosa. So rhinosinusitis is exceedingly common in asthma. And we also know that poorly controlled upper respiratory tract disease can have an adverse effect on asthma. And the corollary to that is that even if you leave the asthma therapy unchanged, if you aggressively and appropriately manage the upper respiratory tract, their asthma seems to get better. Now, whether that's their asthma getting better or the fact that what was interpreted as asthma symptoms are really just symptoms of rhinosinusitis, I can't tell you. But that is also an important point, and it comes I think, on a later slide, and that is, are these symptoms all due to asthma, or are they due to something else? And I would include reflux and rhinosinusitis in that list.
Great. So I think we'll just carry on here, John.
Yep. So what about asthma control? Well, the first thing to say is that all the studies that have been done indicate that patients underestimate their symptoms. You can use validated instruments, and the New Zealand guidelines like to use the asthma control test, the ACT. Or you could kind of do what I do, and that is you ask about symptoms, particularly nocturnal and early morning symptoms. You ask how often they use their short-acting beta agonists. You ask about functional interference, what things can they not do because of asthma, and then you make some sort of assessment of their morbidity. How many courses of oral steroids, how many ED presentations, hospitalizations, that's HA as hospital admissions, etc. So those are all pretty standard things. I think the asthma control test is a validated instrument. I kind of like to ask my own questions because I get a little bit better feel for it, feel for the degree of control. But you can do either. Just assess their control in some shape or form. That's from the BTS. That's a therapeutic escalator for adult asthma. And I'm going to move on very quickly from that because I've summarised it in the first section of this slide. So you start off with a short-acting beta agonist on a PRN basis. Then you have a fairly low threshold for introducing inhaled corticosteroids. What's that threshold look like? More than 3 or 4 puffs of a short-acting beta agonist a week would certainly be, I think, an indication for using inhaled corticosteroids. We probably introduced long-acting beta agonists earlier than previously, so it would be then low-dose inhaled corticosteroids and a LABA, and then higher dose of inhaled corticosteroids plus a LABA. And by higher dose, I mean 800 micrograms of budesonide, 1,000 micrograms of beclomethasone dipropionate, or 500 milligrams per day of fluticasone propionate. So that's what I regard as high dose inhaled corticosteroids, and I call that high dose because those doses represent the plateau of the dose response curve. So in most patients, pushing the dose of inhaled corticosteroids beyond that generally doesn't bring about an improvement in symptoms. So in relation to Bruce's question before, that's what I consider to be the, for the want of a better term, maximal therapy in the community for asthma. A few rules. I think all inhaled corticosteroids are equivalent, allowing for the dose equivalence, if you see what I mean. Mm-hmm. Mm-hmm. So I do not think that there is any tremendous advantage of one inhaled corticosteroid over another. Just remember that the new device, and I'll use the brand name here, Brio Ellipta, contains fluticasone furoate and not fluticasone propionate. And there's a 5-fold difference in potency of those two. So just remember that those are different. I think all the LABAs are equivalent. So one LABA is essentially as good as the next LABA. So LABA, I'm sorry, is long-acting beta agonist. And then, so if you're looking at a long-acting beta agonist inhaled corticosteroid combination, the choice depends on frequency. So twice daily use versus once daily use. That's very much a patient preference. I am aware of no data that shows that twice daily use is, that once daily use is associated with better adherence than twice daily use. And then the device is dependent on the patient preference. All of the current devices deliver drug effectively to the lung if used properly, and therefore the choice of the device is up to the patient. And Bruce and I were discussing this earlier. I think we must be very careful not to place our own what shall we say, preferences onto the patient. And as corny as it sounds, in every clinic room that I work, I have a little box, kind of like a toy box, and in it I have each of the devices. So I'll have a breeze-haler and a handy-haler and a respimat and a turbuhaler and an ellipta device and a pressure-metered dose aerosol and an AccuHaler and so forth. And depending on what drug combination I'm talking about with the patient, I'll say, these are your options. Which of these devices do you think you would most prefer? And give them an opportunity to handle them and open them and see how they can manage the devices if they have arthritis or some other problems, visual impairment, etc. So I think that that's the way I choose the device. I let the patient choose the device. Bruce asked me whether or not you need a fellowship of the Royal Australasian College of Physicians to be able to pronounce the names of all the new agents.
I think that's true, isn't it, John?
Yeah.
If you can pronounce it, you take up a fellowship with the College of Physicians, respiratory division. If Bruce gave me a quiz now and asked me to name the drugs, all of the long-acting beta agonists, all of the long-acting muscarinics, all of the inhaled corticosteroids and all the combinations and all of the devices, I could not do it. And I'll be very, very frank about that. What do? I have a laminated card that sits on the wall of all of my clinic rooms that has the generic names, the brand names, the device, the frequency of use, and also how you can get access to the drugs in terms of whether you needed special authority or the drugs endorsed, etc. So I would not recommend that you spend an enormous amount of time and effort trying to learn all of those different drugs and different drug combinations. As I said, I cheat. I have to look it up each time. So my suggestion would be that you might consider doing the same. So John, just coming back, there was a question about the furoate and the fluticasone being 5 times. Now in the Brio, the fluticasone is 100 micrograms. So is that a relatively low dose of inhaled steroid?
No, that's high. So it's 5 times. So it's about 500 micrograms.
Oh, the furoate is 5 times more potent.
Yeah.
Oh, well, okay. So
that's 500 micrograms of the old fluticasone, which is equivalent to 1,000 micrograms of beclomethasone.
Right. Okay. So that's actually quite. Do you want to just say that again, John? Because I think you see that question there is fluticasone propionate.
No, it's the other way around.
It's the other way around.
Furoate is 5 times more potent than fluticasone propionate.
Right.
Okay. So the recommended doses for, if I can use the brand names, for Brio ellipta and serotype, the the daily inhaled dose of inhaled corticosteroids is equivalent. Okay, right. So serotype 125/25, 2 puffs BD. The inhaled corticosteroid dose for that is the same as Breo-Ellipta, 1 per day.
Well, that's a really good take-home point, John. Jessica just asked, can we get access to the card that has all the different types? So we've got 2 forms of it. John has written out the newly funded COPD inhalers, and we will put that on the website. And there's also the COPD prescribing tool from BPAC, which is a wonderful article. It's got photographs of what the different inhalers look like, and you can spend the next 6 months trying to remember the names and say them back to yourself. So I think John's right. You actually need to have this stuff. It's been a bit much for all of us to sort of cope with 3 new ones, but yep. Nice to have them. But on the other side, it's hard to remember them. So that's the COPD prescribing tool from BPAC, and we'll put John's summary up on the website, which will be linked to the webinar. And that'll all be in the email that we send out to you, just letting you know that the webinar is, you can go back and watch the webinar, but you don't have to go back and watch it if you want to get the resources that have come with it.
Finally, just to say something about the so-called SMART regimen, because that features quite a bit in the New Zealand guidelines. So that's the use of budesonide, an inhaled steroid, and formoterol, a long-acting beta agonist combination. And the SMART regimen is to use that regularly, plus as required as for symptom relief. So the SMART regimen, there's good data supporting this sort of regimen. It has only been shown for budesonide and formoterol combination, and I think it's the BPAC guidelines, sorry, the New Zealand guidelines stress that point, that it's only for that combination.
And that's Symbicort by its trade name.
Trade name is Symbicort. Yes.
So how is that working? Is it the extra, like, what are you doing for the patient there? Are you giving them more steroid? Are you tweaking their airways with the probably, I mean, the evidence is that when you get an exacerbation, increasing the dose of inhaled corticosteroids, doubling it, doesn't help. But I think that using this SMART regimen, I suspect that you are starting to give more inhaled corticosteroids at the earliest sign of a change in status. And you're dilating up the airways at the same time with the long-acting beta agonist. So I can only presume that that's how it's working. That it's for the want of a better term, nipping the impending exacerbation in the bud. So is there an upper limit? You say PRN, but can you keep going to 7, 8, 10 times? PRN?
I don't think there's any evidence to suggest that, Bruce. But I have to say that let's just say that the baseline regimen was 2 puffs BD, so that's 4 times a day. I would think that if you were using that 10 times a day, then that's a time for you to say, this is not working, we need to change strategy.
Right. Yep. Good. Thanks for that.
I mean, there is no evidence, but I'm just...
So just another point, you shouldn't do this with so Symbicort's okay, but not serotype.
Yes, that's right.
Is there a lack of evidence, or
a lack of evidence?
A lack of evidence rather than it. Okay.
Yep.
So that's a pretty good distinction to make there.
Yeah. So one of the things that we are all faced with is poorly controlled asthma despite optimal therapy, and I'm defining optimal therapy as the top of that therapeutic escalator that we talked about a few moments ago. So the first, and some of this is, or a lot of this is repetitive, but it's just putting it together in a different way. So the first thing is, have I got the right diagnosis? Is this really asthma? Am I dealing with hyperventilation or vocal cord dysfunction? Am I dealing with cardiac disease? Am I dealing with another respiratory disease such as bronchiectasis? going back to that other point, are the symptoms actually attributable to asthma, or am I mixing up symptoms of gastroesophageal reflux and rhinosinusitis with those of asthma? And you might think that that is that would be difficult to do, but I can assure you that many patients I see, their asthma is well controlled, but their symptoms relate to their rhinosinusitis or their reflux disease. So now we've got the diagnosis of asthma. We've got it right. We've managed their comorbidities. Still poorly controlled. Well, we look for aggravating factors, smoking, dusts, and I'd include in this occupational exposures. What about their inhaler technique? And specifically, if they have a pressured metered dose inhaler, they should be using that device through a spacer. So again, to use brand names, Seretide. I never use a Seretide a pressured metered dose inhaler other than with a spacer. And if the patient doesn't like the spacer or doesn't want to use the spacer, then I find a different way of delivering the drug rather than just letting them use the pressured metered dose inhaler. You need somehow or other to try to get a handle on their adherence. I know how difficult that is, and I am sure that I am no better at that, doing that than you are. But nevertheless, I think it's important to try and get a handle on that. And finally, and possibly related to the adherence issue, is the whole issue of psychological factors and how they might be impacting on asthma control. And I have certainly been caught out many times in relation to that. And I have also sent patients to see psychologists and psychiatrists to be assured that all was well, only to subsequently find out that the person had severe obsessive compulsive disorder or some other psychological factor that was impacting on the management of their asthma. So that's sort of a little checklist to go through if you are having problems with poorly controlled asthma. So Bruce has already referred to that. If the asthma is still poorly controlled, at the top of the therapeutic escalator, and after you've been through the checklist that was on the last slide, that's an indication for referral. I think that in this day and age, there's no role for oral beta agonists or oral theophylline. There is a very limited role for the so-called mast cell stabilizers in adults. I saw the first patient recently in whom I was convinced that a leukotriene antagonist really made a difference to their asthma. So it does happen, but in my experience it's pretty uncommon. There is very limited data on the use of long-acting antimuscarinic agents, so that's the tiotropiums and the like, in asthma. But the more that we get involved with the asthma COPD overlap, then I think the more justification I think there would be for the use of a long-acting antimuscarinic agent. And of course, where things are going at the moment, the use of monoclonal antibodies. Omalizumab is the one that's currently available in New Zealand. I have to look up the indications for that every time I think of it. But you know, that's one of the reasons for referring. That might be one of the things that we use in poorly controlled asthma. That's an anti-IgE monoclonal. There are now monoclonals against IL-5 and a whole variety of other cytokines that might have a role in asthma. Problem is that all of them involve injections. once daily, twice daily, or the most recent one that we're using at the moment, 4 times daily.
John, just got a question here. If control of rhinosinusitis, this is from Jane, has such an impact on asthma control, what management strategies do you recommend for rhinosinusitis? There was also a question on antihistamines, if you could maybe pull those two in.
Yeah, so what do I use? I use inhaled corticosteroids. I use antihistamines at night. If they are having problems with very sticky upper respiratory tract secretions and they're aware of postnasal drip, they get the symptoms associated with that. You know, they cough as soon as they assume a supine position. They wake up choking with mucus in the back of their throat at night. Then I use saline sinus rinses. If the patients are still having problems on that combination, then I do a CT scan of their sinuses to determine whether or not there might be, they could benefit from endoscopic sinus surgery. So that's my usual treatment regimen for upper respiratory tract disease. Great. And I'm sorry, I misled you a few moments ago. Omalizumab, I think, is used fortnightly, not daily. So I apologise for that mistake.
Great, Karen.
Okay, just a very quick thing on asthma action plans. An asthma action plan gives the patients instructions to identify deteriorating asthma, and if that happens, what to do, and then what to do if that's not successful. So an asthma action plan might be as simple as, if your breathing gets worse so that you have difficulty talking, go to the nearest emergency department, right? So that is, if you like, an exceedingly basic and simple asthma action plan. But of course, what you will do will be refine that over time. So the asthma action plan will evolve. You may use the multicolored asthma action plan that features in the New Zealand guidelines. I don't know how often those are used in general practice, but I think I can safely say that it's many years since a new patient turned up in my clinic with asthma and presented me with a multicolored asthma action plan. So I suspect that those are not used all that frequently. I have already talked about peak flow monitoring. Our experience is that people don't monitor peak flows, and they don't even monitor peak flows in the face of deteriorating asthma symptoms. And so I have, for the most part, not entirely, but for the most part, given up basing the asthma action plan around peak flows, because I don't think people do it.
I remember Harry Ray famously saying many years ago, you probably remember this, perhaps we should be teaching people how to use a telephone rather than
exactly.
fiddling around. That, you know, if they, for some reason, people find these things, we think it's smart to use a peak flow meter, but actually patients find them difficult or they don't make sense to them. And I have to say, the trouble I've always had with that coloured little chart was just the effort thing. I mean, some people, you know, if they don't put any effort in, they've got a peak flow of 50 and you feel like intubating them, you know, yet they're talking to you, and and you know, really, I just found it too hard, and I suspect that's what's happened. I think it's one of those things that, you know, if you're not seeing it at your clinic, then I suspect we're not doing it anymore, and one wonders whether these things perhaps need to be questioned, but not my position to say it. I was going to say, John, we'll go through till 9 o'clock. And we'll definitely stop then.
I will be very quick in the last 2 slides. Because
we're still getting questions coming through, so get those questions in, and then we can have a Q&A at the end, and then we'll finish at 9.
Very quickly, so I've covered that, I think. The indications for referral: severe asthma, high morbidity, especially in the face of maximal therapy, and after having gone through that checklist. If the response to the various forms of therapy is atypical, certainly less than what you would expect. In other words, is there an atypical clinical course? Asthma should have a normal chest, asthmatic should have a normal chest radiograph. If there's an abnormality on the chest radiograph, that's a reason for referring. But, you know, sometimes it comes down to, and I get these referrals all the time that say something along the lines of, things just don't seem right to me. And those referrals, in my experience, are generally spot on. Things were not right. And so it's not inappropriate for you to say things are just not right. The assessment of a severe attack of asthma is actually pretty straightforward. And I tell students to put their hands behind their back, stand at the entrance to the resuscitation room and watch for 15 seconds. Because generally speaking, they can assess all of these things. Level of consciousness, cyanosis, speech, are they speaking in words, phrases, sentences, paragraphs? What's their respiratory rate? Are they using accessory muscles? They've usually got monitors on, so we've got their heart rate and their oxygen saturations. People who are sick can't use peak flows. And someone actually said in response to the notes that Bruce set out, pulsus paradoxus. I don't know whether any of you have ever tried to measure pulsus paradoxus, even in a patient whose respiratory rate is normal. But I would suggest that it is absolutely impossible in someone with acute severe asthma, and I haven't done it in the last 30 years, and I don't think I've actually seen it recorded in a similar amount of time. So you auscultate the chest. Why? You auscultate the chest to make sure that there's air entry on both sides and that the patient hasn't got a pneumothorax, and maybe you're looking for the signs of a pneumonia. You do a chest radiograph in acute asthma for the same reasons, to exclude a pneumothorax and to exclude other complications. Remember that you use oxygen only for the treatment of hypoxemia, and there is increasing data on supplemental oxygen in asthma being potentially detrimental. So you want to maintain an oxygen saturation of 92% or more. If it's less, by all means give supplemental oxygen, but supplemental oxygen is not an automatic part of the management. They need short-acting beta agonists. For mild to moderate asthma, a spacer is as good as a nebulizer, but if they're really sick, they need a nebulizer. They need steroids, and if they are still remain sick with frequent nebulizers and with steroids on board after a couple of hours, then that's the time to call the ambulance, call for an ambulance. If you feel as though you need to do something, intravenous magnesium sulfate is more appropriate than intravenous beta agonists. And although it is used in some centres, there is no evidence that NIV is useful for the that's non-invasive ventilation, and under that, strictly speaking, should only be bi-level ventilation, but often they talk about CPAP for that. I don't think there is any evidence that either CPAP or bi-level ventilation should be used in the management of acute asthma. And then you just monitor them. You monitor their level of consciousness, their respiratory rate, their speech, their use of accessory muscles. And it's pretty straightforward then if they're getting better or getting worse.
Very encouraging, John, to hear you say that about nebulizers, because I always felt in general practice patients could use the spacer at home and come to us for the magic machine. And when they came and we just stuck them on a spacer, they seemed to be incredibly disappointed. Yeah. And you know, I think the nebulizer, as you say, it's effort free, and it does you know, it's nice that it still has a place. So we've got some more questions here. John, do you want to?
No, that's it. I'm finished.
Now, Suanna had Now, Serena, your questions come up in about 3 or 4 places, and I think you've written it on your screen, but other people have ducked in between time. So I don't know if you can try and put yours into one space, and then I can read it out. Just that it's it's a bit like a TV series, and I'm missing a few bits here. So thank you. Okay, so Robert's got quite a good suggestion here. How do you teach the use of saline nasal rinse? I get the patient to do a Dr. Google search and Nellymed, which is the company that makes the ones here, sinus rinse YouTube. This is worth getting patients to see to make sure they use nasal saline rinse correctly. Also important to get them to use correct recipe with avoidance of table salt, which contains additives. So anything to add to that, John? Or?
Yeah, look, I agree with that. I'm not so sure as to how important the additives in table salt are. The little sachets, for what they contain, are relatively expensive for some patients, and whilst I accept that there might be some disadvantages of using table salt and bicarbonate, that has to be, I think, balanced against, the financial issues for the patient. So very happy for them to use the little Neomed sachets. I do get patients to make up their own solutions sometimes, but I very much take the point about getting people to look on that website about the appropriate use of the appropriate administration, should I say, of saline nasal rinses.
Could I cheekily say perhaps if you take table salt, it's one way to get the iodine on board? Okay, so Suanna has redone her question, thank you. So for a patient regularly, this is presumably a patient with asthma, regularly using antihistamines, doing sinus rinses every 2 to 3 days, and a relatively clear sinus CT, who is on Butacort nasal spray, what next? She's also doing twice daily peak flows showing 20 to 30 points lower in the morning on waking, BP consistently fine, oxygen sats been 98 on last few visits. So what would you recommend Suanna do with
well, that? in terms of the management of their upper respiratory tract disease, I would have thought you're doing everything just about right there. That peak flow variation is not all that surprising. Remember that there is a normal diurnal variation in the airway caliber, so that in all of us, our airway caliber is slightly lower in the early hours of the morning, and therefore, and still may be lower on wakening. So you might expect that your peak flows might be 20 or 30 litres per minute lower in the morning than they are late afternoon, especially if you've got peak flows around 300, 400, 500. So I don't think that that's necessarily abnormal diurnal variation. Oxygen saturations are obviously fine. So if the question is the patient still got symptoms with that, I think that's one of those things where you've probably just about done everything you can, and that might be someone that you say, I'd like someone else to have a think about this and see if there's anything else that can be done to improve their symptoms.
So Suanna, your question, is your patient still symptomatic from their asthma point of view? Are they still wheezing? Is that what you're saying? Just another question. While you're answering that, Suanna, what type of spacer do you recommend? The volumetric ones tend to sit on the top shelf. Indications for this use, they're the big ones, aren't they?
Yeah. And I have to say that I prefer those. Yes, I guess there is a risk of them being on the top shelf, but I tell people to use their inhaled corticosteroids through the inhaled corticosteroids plus beta agonists through the spacer, and I tell them to leave the inhaler stuck in the end of the spacer, and I tell them to leave the spacer in the bathroom, preferably as close as they can to their toothbrush. so that when they clean their teeth, they use their, so before they clean their teeth, they use their inhaler through the spacer. Then as part of cleaning their teeth is essentially the rinse, gargle and spit, not that you supposedly need it in association with a spacer. If they are then using they need to have a spacer for the use of their short-acting beta agonist throughout the day, then you can give them a small spacer to take in their purse, briefcase, whatever, to use during the day.
Suenna's come back and said, yes, still coughing up gunk regularly, which does not grow on cultures. That raises the point of any value in doing sputum cultures in the community, full stop, and with asthma.
In asthma, probably not.
Yeah.
Very occasionally in COPD, because in COPD, the presence of so-called potentially pathogenic microorganisms is a pointer, one, to exacerbations, and two, to the possibility that they might also have underlying bronchiectasis. So if the sputum culture shows Haemophilus, Pseudomonas, Moraxella catarrhalis, etc., those are potentially significant in the COPD population, but I tend not to do sputum cultures in the asthma population.
So it sounds like Suenna's patient probably needs to see a respiratory.
Yeah,
she's gone above and beyond the call of duty.
I think so, and I think that, you know, that might be the patient that you want to do an HRCT scan on to see if there's anything else going on in their lungs. So has this patient got bronchiectasis? Do they have this somewhat unusual condition of inflammatory bronchiolitis, which we are seeing more and more of, and is a cause for ongoing cough and shortness of breath following a seemingly ordinary intercurrent respiratory tract infection?
Okay, well, in a moment I'm just going to go through, I've written down a list of take-home messages here, but I'd like to thank John for his expert and excellent content tonight, and to thank Pharmac for supporting the webinar. Pharmac don't give us any direction on what, so the content tonight comes to you from the Goodfellow Unit and from John in particular. I'll just run through these, John, and if you object, then stick your finger up, and then we'll close down. So cough is really the only manifestation of asthma. Peak flow, difficult to demonstrate a 12% change in peak flow. The 0.7 FEV1 to FEVC ratio, probably in young people it should be 0.8, and in older people 0.65. Peak flow really only useful for an individual to monitor their progress, not an outright diagnosis. To do a clinical trial of oral steroids, 40 milligrams 2 to 3 days and 20 milligrams 2 to 3 days, but John's open to 40 milligrams for 4 to 6 days, I think. If you're going to give prednisone in an acute attack, probably 40 milligrams for 5 days. We sort of touched upon that. We should always be looking with asthmatic patients for GORD or chronic rhinosinusitis. That 1,000 micrograms of beclomethasone is equal to 500 micrograms of flexitide is equal to 800 micrograms of budesonide, micrograms, and the furoate 100 milligrams equals, so furoate at 100 is a high dose. Okay. Smart therapy only used with Sympacort only, not the other one. For chronic rhinosinusitis, saline rinse, antihistamines at night, and inhaled corticosteroids, and that don't throw away your office nebulizer. It is useful in the severe asthmatics, and it does have a bit of mechanical magic to it. So John, thank you very much for being with us tonight, and I'd like to thank Paul Keogh and thank the audience. That was a great number of questions we got tonight. This is recorded, so if you have friends who want to partake, then then tell them about it. We had over 400 people register for tonight, so that's I think that's a record, so that's fantastic. So thank you very much, and good night, everybody.
Good night.
Muted.